and then we're publishing that recording. So that's just to explain why there's a slight difference to the format today. So I'd like to welcome everyone to this board meeting of Sussex Partnership NHS Foundation Trust. I need to welcome Jane Vickers. You're representing Jan Charlton today, and you're very, very welcome here this afternoon. Jackie Buckley will be joining us at 3 o'clock to present the Freedom to Speak Up Guardian report. In terms of apologies for absence, as I've just alluded to, we've received apologies from Dan Charlton, from Charlotte Carithwellin, and Martin Richards. So those are the apologies for this afternoon. Are there any declarations of interest that haven't previously been declared that are relevant? No, thank you very much. Minutes of the board meeting held on the 18th of May. Can I seek approval for those, please? It appears that I can. And as I understand it, I had a look at the action tracker. It seems to me that that's up to date. Is everyone content that we're up to date with that? We are. I haven't received any questions from members of the public, and then but there is something we're going to have a little look at, because through lockdown we used to get questions to the public, and through lockdown we only got one that I can recall, and I think we just need to think about how we make sure people understand that that is something that is available to them. So if I could then move to the chair's report, I'll take it as read. I'm happy to take any questions, but I do need to just seek your approval for the Appointments and Remuneration Committee terms of reference. So can I have that? And are there any questions on the chair's report? No, fine. Okay, thank you. In which case, we will move to the Chief Executive's report, please.
Thank you very much, Peter. So I want to start by saying that as part of my induction, I've been meeting with one-to-one with senior leaders across the trust. And I spend 30 minutes with them each, and I think it's going to be a rolling programme going forward because there are a vast number of them, and asking them to tell me a bit about themselves, their role, what they're proud of, what their challenges are, what they want, what they're doing about it, and what do they want from me as a chief executive in order to enable them to deliver high quality care. Also give them a chance to ask me any questions they want to ask. And I have to say I've thoroughly enjoyed it and have found it really insightful. I've heard so many examples of innovation and compassion and high quality care. And when asked about the challenges, consistently the feedback has been about getting the workforce, being allowed to be creative when recruiting people, making the process as quick and easy as possible. And linked to this, how we nurture trainees and talent to support the leaders and workforce of the future. I've also heard frustrations about the pace in which we bring about change, and then how we share and spread learning. What I have come away from overarchingly is that we have a strong group of leaders that mean we can tackle some of the challenges we're going to hear about today through them, because they are so committed and so driven. So I'll take the paper as read, but the things I want to highlight, that NHS Sussex was established on the 1st of July. It's really important, I think, for us to recognise that we are the ICS, that the ICS isn't over there, that we are part of the ICS, and we're part of the health and care system in Sussex. And the people that we serve are the people of Sussex. On the launch day, we were fortunate enough to have Amanda Pritchard, the NHS Chief Executive, visit Langley Green, which I thought was great to have her on the first day of the launch of the ICS and ICBs to actually come to a mental health trust. And she was really impressed with the staff that she met. A patient showed her around his room and his bathroom and showed him his artwork. And she really enjoyed visiting, gave some really positive feedback about the compassion and innovative services such as Home First that are being delivered there. Exec directors have been attending NHS Sussex launch events throughout Sussex, so we've made sure we've been present at most, I think all of them, and there's been a welcome focus in the discussion on mental health and learning disability and the challenges and opportunities we face. As you know, we are committed to delivering place-based services and place-based models of care by 2023, April 2023. And over this month, we've been welcoming feedback from individuals that will inform our thinking about how that structure will take place. June the 27th saw the draft mental health bill published, and I spoke about it the last time at board, so I won't reiterate what that's about, but the draft bill is now subject to the pre-legislative scrutiny, where the Parliamentary Select Committee will examine the draft in detail before the final version is published. Since the last board, the Messenger report has been published, and I'm sure you will have heard about that in the news and shown an interest in that. I think the review focuses on the best ways to strengthen leadership and management across the health and social care settings. It's primarily health, it touches on social care, and also that made 7 recommendations that have been published, and we're considering how we take those forward as part of our leadership development. The government's accepted the recommendations of the independent NHS pay review bodies in full, and so that we will be implementing that, but at the same time we are working with staff side and staff to look at practical ways to address the cost of living crisis that we're in. That has become quite a responsive, so as we're hearing from other trusts and getting ideas, we're adding to our offer. So since the last time we've met, we've increased our payable rate, mileage rate for fossil fuel mileage by 5 pence per mile. So it shows us sort of changes we're going through. You will all be aware that health and social care remains under significant pressure. And I think normally we see this level of pressure in winter, and this is summer. And so we are starting our winter preparedness now, because it looks like this is going to be a sustained level of demand and need in the community across services. You'll see in our performance report, we've had a significant increase in out-of-area placements, and it's due to a number of reasons that we have rehearsed many times before, and I'll talk a bit more about that a bit later, but we're looking at some alternative options to inpatient admissions. The immunisation programme is about to be launched. The booster programme, the guidelines has been published, and this year you'll remember that through COVID the sequin money attached to the immunisation wasn't present. It's now being reintroduced. So if we achieve 70% compliance, we get just under 575,000, and if we get 90%, then we'll get £820,000. So we've started to think about that. We've looked at our approach at exec this week. We've agreed the principles, and we're developing that into a really robust plan. And I'd be very clear, we're aiming at 90%, not 70%. Sadly, the findings of the leader, I think it's really important to talk about this. It's a national paper that came out, the National Review, Learning from Deaths of People with Autism and Learning Disability, and it makes for quite shocking reading. There are some positives in there, such as the deaths from pneumonia have fallen, and the learning disability liaison nurses in acute hospitals are valued. But what really stood out for me is that 49% of the deaths of people with a learning disability were classified as avoidable deaths, and a new category of cardiovascular disease was added to those that is disproportionate. Also, minority ethnic groups were not represented proportionately in those that were investigated and reported to leader, but when they were, mixed ethnicity was overrepresented in the avoidable deaths. There's an overrepresentation of people dying away from their usual residence and not in hospital. That means that generally they're in continuing care, so not with their usual caregivers. So there's some learning there. And DNA, CPR, do not resuscitate, directives were not correctly followed in 60% of cases. And males die 22 years younger and females 26 years younger. And I've said those on purpose quite starkly, because I think it really drives home the message that although progress is being made for the learning disability population, we've still got a long way to go. And as system leaders for learning disability and mental health, I think we need to be talking about that. So I've shared the findings with the chief executives across the country, across the Sussex, and we're thinking about how we can work together to improve those stats locally. Complaints. I've set up a new complaints process where I read every complaint and every response and add a letter from me that is just a 1 page long, but really consolidates what they're saying and how sorry we are for their experience, whatever that might be. And I think one of the things that I am pleased about is the timeliness of responses is improving and the tone is improving. We are having, and the complaints, my sense is the complaints over the 3 weeks I've done it are about waiting times and process and communication. But when people are in care, we have very few complaints about the actual care. So that period of waiting is the time that is really critical, which links to our breakthrough objectives and what we're doing. I want to end on a positive note, and that is that we received planning permission for the rises, the Bexhill build, and Usman and his team and Sally, his predecessor, did a phenomenal job in putting the case forward and getting that approved. So thank you very much. I'm happy to answer any questions.
Thank you. Are there any questions for Jane? Anna.
Thanks, Jane. That was a really comprehensive update. I wanted to come back to the leader report, and just because I think there's some differences between our trends and patterns. So we have a particular issue with record keeping around physical health, that I think we know we've got that issue and we know how we're dealing with it. The one I didn't feel we'd quite articulated it locally was the discrepancy on BAME. And so my question is, are we, given the national picture, are we going to do some monitoring around that? Is it something that we already know that's perhaps just not visible to me? But I just felt it was such an important area. And in fact, you've highlighted it as well. I just wanted to know what we were doing in terms of monitoring.
So overall,
so Jane, I've got Joe waving at me, so I'll let Joe come in and then ask you to respond to both, if that's all right, Joe.
Thank you. Actually, on that very question, Anna, last week or the week before, in my discussion with Mandy Burton and Rebecca, Director of Legal, I picked up on that point because we just don't have that sort of data, and Rebecca is going to follow it up. So watch this space on that.
Thank you, Joe. Sorry, Jane, please.
No, that's fine. So I think university, we do not record ethnicity as well as we should have done. And it's something that certainly Claire Walcott picked up with her suicide review of the suicide as well. So it is a very distinct piece of work we're doing across the board in understanding ethnicity and our outcomes as a result. And that will include leader and mortality governance.
Thank you. Can I just have one more question, Peter?
Yeah.
It's about complaints handling. I think I really welcome your approach. I'm sure it's a huge amount of extra work for you, but I think it's a really good strategy. I just wonder if we're going to get any update on the impact of that. It's quite hard to do it before and after, but it feels too important just to say, well, we note that it's happening. Is there some kind of evaluation of the impact of that? I just wondered whether that was in your mind.
That's a really good point. I'm not sure how I'd evaluate it. I was thinking about it today when I was reading two that were, I was going to say re-complaints. That's not right. That they're doing a complaint for a second time. They've come back because they weren't satisfied with the first complaint. And I was thinking we need to have a look at that. How many are coming back with the same complaint because it hasn't been resolved the first time? So I think that would be a really good measure. And we can certainly do that through the integrated experience report that goes to Quality Committee.
Yeah.
Thank you.
Jane, can I just check something in terms of, so when you were talking about disaggregating data so that we understand whether things are working for different groups or particularly not working for particular groups, is that across the board as well as this cohort?
Yes. It's
okay.
Across all of our performance metrics. We're going to be looking at it.
Because that is something the board asked for in response to, in the autumn of 2020, we said that was something we really wanted to prioritise, so we weren't hiding behind averages.
No, absolutely. We're doing it in relation to different teams, but protected characteristics, we're doing the work on getting the baseline data right first. I'm aware Claire's got her hand up and she's leading this, so I'm going to let her talk.
I'm aware of her hand being up as well, but I just wanted to get my question answered. Claire.
And I was going to answer it exactly as Jane says. So yes, as part of the Health Inequalities work stream, Gurpreet and I are leading on both ensuring that we are capturing data in a way that is clinically meaningful and is able to follow someone's pathway as their protected characteristics may change through their time with services, and that we are then able to look at how that compares with the wider population, looking at the needs assessment of the local area, that we can then look at developing in according with that sort of reports and service changes to address those inequalities. But so yes, definitely, and that's across the board, all services that we are working on that.
So when would that come through in terms of our performance? When would we start to see that coming through in terms of our performance reporting?
I'm not, well, maybe Gurpreet can answer in terms of performance reporting of timescale.
So, Peter, we have a programme of work in order to develop that. I can bring the timeline back to the board if you require. But essentially what it requires is the building of forms within care notes to support the capture. So we've got outdated forms, we've got a new set of data requirements from National, which outlines exactly what protected characteristics and the various subfields that we need to be collecting. So that's being built. We've also, at the same time, we're also thinking about linking together data from all of our systems. So we believe very soon we'll get an 8% increase in our protected characteristics data, for example, around ethnicity, by pulling data together. And the third stream of work that we're doing is working with what's known as the Sussex Integrated Data Set, which is a set of data from across the whole system. And so if you imagine patients have multiple touch points where they will be asked about protected characteristics, if we bring it together, we'll find that the whole, we have much better overall quality of data around this. So those are the three streams of work that are happening as we speak.
Okay, thank you. Jane.
So we've taken the board approach of the three horizons and doing immediate piece of work around data cleansing and getting the, just everybody, can you just enter in the bits, and that should be done relatively quickly. At the end of, I would say, Q3, we should have some baseline data. And then there's more robust kind of making sure we've got every protected characteristic and the underlying system to do it all. That's going to take a lot longer and is going to be an incremental change over time.
Okay, thank you. Anything else on the Chief Exec's report? So we really congratulate everyone who was involved in getting the outline planning permission over the line. That was something that we have said is important for East Sussex, because East Sussex has not had the best facilities. So well done to everyone involved in that. Welcome the changes to complaints handling and the fact that obviously over time we can then get more granular understanding of what it is that's working and not working. And particularly while we have, obviously we're trying to get waiting times down, but while we have long waiting times, understanding what's happening to people in that process. And also then specifically around the leader report, trying to make sure we really are focusing on some of the findings that are pertinent to our organisation as a system leader. We're progressing that, and to really follow through on the board's request that we have more aggregation of data around protected characteristics, so we understand which services work for who and which services don't work for who, and who's accessing services correctly or not. Thank you very much. So the breakthrough objective for today is recruitment and retention. I think we were aware when we looked at the community transformation that in April that there were clearly there's a lot of interdependency with recruitment and retention. So we asked for this to come today, and I think I'm handing to Claire Webster. Is that right?
You are indeed. Thank you, Peter.
Welcome.
If it's okay to go through the slides first of all, and then to pick up any questions afterwards, that would be
Please
great.
do. Please do.
Thank you. So on the first slide there, you'll see there's just a quick summary of the published objectives in terms of this particular aspect, and just in red is the update as to where we are at this moment in time. On the first one, we've suffered with the same issue as others, I'm afraid, in terms of not being able to recruit to our new roles lead, but we have now done so, and in the meantime the team had been starting to collect some information around new roles, and the new roles lead who we have recruited, who is an internal person and who is excellent and will hit the ground running, will, I think, move that forward at pace. The second one, and it links to some of the discussion that we had earlier with Bex, is around reviewing our recruitment procedures and looking at how we are more inclusive in our practices and what is it we can do around our processes that will help that. And that person is due to start very shortly. And we're also looking at getting external specialist advice as part of that objective as well. And then the final one that's listed there, we're well on track with. That's a really popular program, so that one's moving forward and nicely. So if I could go on to the next slide, Dom, thank you. Just in terms of where we're at, the context that we're working within, and I don't think this will be a surprise to any of you. You'll see in the top boxes there the national context in terms of numbers of vacancies, and the breakdown of some of those, and then in terms of the trust and our situation. And there's a whole raft of things there that I would flag in terms of the pandemic. People may well have heard about the Great Resignation, which is not unique to the NHS, but is the offshoot of the pandemic, and people deciding they hung in there during it, but now they've had enough. We've got increased demand for our services at the moment, and along with increased demand, we've got new services and we've got redesigned services, which means our establishment is growing at the same time as we're trying to recruit to our existing vacancies. We've got accommodation shortages. We know living in the southeast is expensive, and that is causing us, concern along with our neighbouring trusts. And the cost of living issues at the moment are really well documented, so I don't need to go into that. In terms of the NHS context, we know, as indicated above, that everybody is struggling in terms of vacancy levels, and we are in effect fishing in the same pool. And we're also fishing in a really buoyant recruitment market. So latest figures show us that there are more jobs, more vacancies out there than there are unemployed. So our recruitment challenges are not just about our nurses or our medics, for example. They stretched all sorts of different roles where we are having to work very hard to attract applications. We are in the thick of escalating our international recruitment program. But that in itself creates challenges for us, partly around RMNs not being out there in huge numbers internationally either, but add into that the list of countries that we can source international nurses from constantly changes, and where one day a country that is on the list will then come off the list, and so our market is constantly moving. In terms of the age profile, we know we have a workforce that's aging, and we also know that mental health officer status means that there are people who can go earlier than other, some of our colleagues, and so that puts additional pressure on us. Certainly in terms of requirement queries, post-pandemic, the NHS Business Services Authority had seen something like a 25% increase in queries around retirement, so we know that people are looking to go or exploring going if they can. We know that changes in terms of our services and the design of our services and trying to bring in new roles requires input from the very people having to deliver those services, and that's a challenge to people's capacity. And we also know that quite often where we're redesigning or looking at new services, that's attractive to our existing staff. So we see turnover within the organisation, which is good because we fill one post, but we leave a gap somewhere else. So a lot of our focus is on our external activity, although, equally it's great that people are moving and progressing within the organisation. Thank you, John. So I just wanted to show you some figures last year and comparatively this year. The figures in May, June 2021 that you'll see there were from a previous presentation that Gavin had brought to the board, and I've updated those. So what you'll see from that is we have increased our numbers in terms of our establishment, but at the same time as we are increasing our whole-time equivalents, we are also increasing the number of jobs that we are trying to fill. We have got fewer vacancies, which is great news, still more than we'd want, but we have made progress, which you'll see shortly in terms of our trajectory from last year. And despite the incredible number of recruitment episodes that we worked through, our time to hire actually has remained constant, which is fabulous news. We are constantly looking at how we can minimise the touch points for managers as part of that process, how we can make sure that they their input is limited as much as possible, but also at the same time trying to make sure that it's a good experience for our candidates who are applying. You'll see this time last year, or just a bit earlier, we had 96 external candidates appointed. We've remained fairly constant in June with 92. And again, the figures haven't radically changed in terms of our total recruitment numbers. So 179 in total during May, June last year, 156 in June of this year. But the total number of vacancies going through the system in June of last year, 968, June of this year, 1,340. So you can see from that the significant hike in activity of the number of jobs that we are out there advertising, trying to fill. But I would want to flag that even with that, we are, by and large, managing to maintain our time to hire, which is a significant achievement, I think. I might be biased. In terms of turnover, we have seen over the course of the pandemic a significant drop in our turnover figures, but over the last few months, the last 7 to 8 months, we did see a significant rise in our turnover, likely linked to the pandemic and the Great Resignation. That has started to come down again now. It's currently sitting at 15.9 against our target of 15%. So what are we doing about it at this point in time? Oh, I'm sorry, I've leapt ahead a slide. Thank you, Don. So just to show you in terms of how we're looking this year as opposed to our progress last year. So you'll see last year we overachieved in terms of the breakthrough objective that was set. But we did have to sort of hold our breath because there were swings and roundabouts over the course of the year where we fell below and then we escalated near the end of the year. Some of that is linked to seasonal changes, people looking for new jobs in the new year and such like. Some of it is linked to things like when new graduates come in. So, there are a raft of things that can affect it, but activity really started to ramp up in the latter part of the year. We are seeing a similar trend at this point in time. So we've sort of been hanging in there until the most recent month when we've seen a drop, but you'll see that's reflected in last year. So we still remain positive that we will be on track, and we're certainly throwing everything at it to make sure that we're doing our darndest to get us to that breakthrough objective and above and beyond if we possibly can. But just so that you can see how things are progressing at the moment. Moving on, in terms of what we are doing to try and achieve that growth, there are a whole range of things, and I could talk about it for a very long time, but I won't because it will be tedious for lots of you. In terms of our talent acquisition, we are working hard, as I've mentioned earlier, on the recruitment experience. What is it like for candidates? What is it like for managers? Trying to make that smooth as possible. And we have got a talent acquisition team now that do a lot of work around the experience, around campaigns, around how we're working more closely with managers, either around geography or around specific roles or a specific profession. And I do hear a lot of positive feedback about the support from that team, and I'm hoping that others do as well. We've done a lot of work around new roles, and that will really start to come into its own a bit more, I think, when our new roles lead starts in September time. And that, you know, is a variety of different things. From example, we last year ran our first process to recruit physician associates. We have things like our graduate mental health practitioners. So, you know, a whole different list of things that we will be, you know, promoting in a much, much broader way and supporting managers with that. But that work has already been happening. And in our away day, we talked about becoming an anchor organisation, and part of the work that the workforce planning team was already engaged with is our voluntary and community sector, and how we can work with them around their ability to help us with our workforce challenges. So that work is already taking place, although we know there's more to do on that. In terms of retention, we have been focusing on fulfilling careers for people, trying to make sure that people are happy in what they're doing and where they can see themselves going. And an example of that is, you know, we have our nurse associate program where people can move through the various levels to eventually become a qualified nurse, or indeed to move on into other more specialist or managerial roles as part of that. We are working on talent management through a leadership development program, but again, I'll come back to that. And we are in the thick of getting ready to roll out our band 2 to 3 upgrades in inpatient settings. So where we will move staff up, and we anticipate that that will help with our retention as well as our recruitment. Incentives wise, Jane mentioned earlier on around the work that we're doing with our staff side around trying to support people with cost of living support group. And examples around that include our mileage additional payment that people are receiving at the moment. But we also look at other financial incentives. So as an example, we've got a new group now, which is chaired by John, which looks at applications to apply a specific payment or some sort of additional enhancement where they make a case as to why it would be necessary for that role. We also are working on our health and wellbeing offer, and just as an example of that, we fund our team days through our health and wellbeing fund, which are really well received and people really enjoy them, and we're in our next round of that at the moment. And then also continuing professional development for all of our staff, you know, which is picked up through our supervision and appraisal processes, but also there is formal arrangements that people can apply to for that. Our flexible workforce, you will all be aware that we're working very hard on the reduction of our agency costs at the moment. And again, the work of John and Mandy in helping to address that has been invaluable. And we are starting to see the green shoots of that work coming through in terms of increased fill rates through our framework agencies and bank workers. And added to that, we are looking at our bank team to review just how that team operates. We put some additional support in there to help managers with some of the trickier issues we sometimes have with bank workers, but also trying to make it a more inclusive process where bank workers feel like part of the team as opposed to feeling like a separate arm of the organisation. Yeah. With the help of comms, we've been focusing on the attractiveness of where we are and our careers website, and then we are working hard on our data and how we measure our progress. And then last of all, the work that's still to come, some of that overlaps with work that we're already doing, but in terms of talent acquisition, we are looking at, in fact, I've got a paper ready to come to Executive Committee around the engagement of a specialist to help us with an employee value proposition. So really making us different, really creating a brand for us. We're looking at non-recruitment solutions, and that's working with Gurpreet's team and thinking about digital solutions as just one example. We're in the thick of a new to health pilot that is about the onboarding and retention of healthcare assistants, healthcare support workers, because they are the staff group where we see the highest turnover. So how do we hook them in? we're in the thick of looking at how we retain people. So we are working on our healthcare academy and how we expand that so that people can see the career pathway that comes through that for those who are looking to try out health roles. And we are, again, we've got a piece of work coming to the exec committee on band 5 to 6 moves and the job descriptions and the framework that would support that move. In terms of incentives, you'll be aware we have recently agreed to look at some accommodation arrangements as part of our international nurse recruitment. And we would want to, once we've got that, properly bedded in, we'd want to look at how we roll that out further for some of our hard to recruit roles so that it's not just about our international nurses. We're also looking at other incentives around our well-being of staff and how we really develop that psychological contract so that they feel well cared for and well supported. And that includes things like we're currently reviewing the procurement of our occupational health provider and our employment assistance program, where, as I mentioned earlier, working on more wellbeing events. We have our Wellbeing Wednesday that goes out every week, and we are continuing to develop that. I could talk a long time about the wellbeing offer, where you'll all be familiar with the Staff in Mind and the expansion that we're looking at as part of that. Our flexible workforce, I've mentioned, looking at how we can rebrand and really make that a more inclusive thing. So you're not an afterthought if you're a bank worker, you're part of a team. How do we make that easier for people, and how do we support managers with the engagement of bank workers? And then communications wise, how we make sure as part of any specialist recruitment advice, we work closely with the comms team and really getting the benefit of that and developing continuing to develop our careers website. And then again, continuing to look at what do we find is working, what's not working, where are we getting the most benefit, how do we make sure we're putting the money we're spending on this into the right places, and where are our hotspots, how do we make sure we're addressing those. If we can, if we've got it's working in one place and it's not in another, what is it we need to do to target? Whistle stop tour, sorry, I've glossed over loads, I know, but happy to take questions.
Okay, Claire. I think that's really helpful, and it's particularly helpful to have the trajectory data. I think that sets everything in a context, both in terms of last year's trajectory and where we are with this year's trajectory. So that was particularly helpful, as well as trying to summarize a lot of activity. I have a couple of questions, but let me move to other people first. Nitin.
Thanks, Chair. Claire, thanks a lot for that. Really helpful. I know at the last FNI, we talked quite a bit about workforce and some of the pressures that we are getting on the financial side, obviously, as we are getting more people from outside. I just wanted to ask two questions. When I look at this graph on slide 5, where you have the workforce update from last year, we have the plan gray line, and we have the actual going above it. Obviously, we didn't meet our vacancies last year, so I'm assuming the plan is set as something that is an achievable plan rather than all vacancies. Number one, so I just wanted to understand, how is the plan set? Is the plan set at a vacancy factor of 12%, which is the average, or is it set at a vacancy factor of 15%, which is, and where do you see that trajectory? What is the, right now we are 4% above or 3.5% above our vacancy factor from last year. Where do you see that ending at the end of the year? Where are we likely to be, given all the efforts that we're doing?
So in terms of setting the objective, last year we had an objective that was an increase of 300 whole-time equivalents. So it was what we thought was achievable in terms of trying to grow the workforce in totality, as opposed to linking it directly to the vacancy factor. And given having achieved over that 422 increase last year, we decided to increase what we were looking to go for this year in totality. So 400 additional whole-time equivalents this year. And that is a challenge, but we're hoping that, potentially we can improve on that again above what our target is. I'm so sorry, I can't remember what the second part of your question was.
I was asking, where do you think we will end up given the trajectory right now in terms of vacancy factor by the end of the year, given that we are right now running 25% ahead of last year, let's say?
I think the challenge is that in terms of our number of vacancies, we keep adding to our establishment. So we are constantly chasing something that's growing around us. And so, I would like to think that we can keep up with that growth in terms of the proportion. That's the aspiration. But ultimately, we're focusing on the breakthrough objective of adding an additional 400 full-time equivalents to our establishment overall. Does that help? I'm so sorry.
Nitin, does that answer your question?
It does, and I'll come back and ask. Yeah, that's fine. Thank you.
Right. Okay, Mandy.
Thank you. I suppose I just wanted to add that I'm really clear that this needs significant clinical leadership and collective leadership in order to address the issues around vacancies, recruitment and retention. I've been working with Claire and the team, but really emphasising to the professional leads across the group, social work, psychological therapies, nursing and allied health professions, that workforce has to be front and centre of their professional strategy. So to really push forward that we need to be thinking 1 year ahead, 2 years ahead. We're not just in the here and now. So I've been talking to the social work lead in relation to the first year post-training for social work. In one of our CDSs, a very small part of our CDS, we've got 53 social workers now, which is increased by 2/3. And I think the structures around supporting staff with transferable skills from across community nursing, health visiting, we need to be really thinking about how we support that process and make sure we have the structures in place to get the supervision right when people with transferable skills, professionals join our trust, but also enable that retention through very good, strong supervision, appraisals and mandatory training. I think as a big mental health trust, we have a range of clinical expertise that enables a real bespoke training package to any professionals who join our trust from a different professional background. And I just think it needs to be led clinically across the professional group. So really working closely with Claire Webster and the team to make sure that the professional leads are front and centre of some of those conversations around reducing temporary agency staffing and temporary staffing, and also having a real focus on recruitment and retention.
Thank you, John.
Thank you, Chair. It's more a reflection rather than a question, just building on some of what Claire said. So I think it's just, I wanted to just update the board on what I feel is an enhanced working relationship between operational services and HR, which I think we can evidence in a number of ways, not least through the Christmas and Easter planning work that we did, the development of the recruitment and retention oversight board, the close weekly plans that we have with the supporting our acute staffing position, working very closely with the temporary staffing team. It just feels like that has improved significantly, and I think that just leads us in good stead for the more strategic piece as well.
Okay, thank you. Now I've got Kevin and Anna. Kevin first.
I'll be quick. A really comprehensive presentation, a smorgasbord of last year and this year initiatives around recruitment, retention, and the life cycle of the employee. I guess my question is, and it's how are you going to notice which ones are working, which ones are not working? And we got a lot of lagging indicators, very few leading indicators as to what's working. and also slightly concerned that there wasn't any predictive validity to the plan, as in we couldn't say where we're going to get to by the end of the year. So I guess it's that detail of how you notice what's working, what's not working, and yeah, how we manage that.
So in terms of what's working and what's not working, we do already measure a whole raft of things that might be linked to process timings and how long they take. We're always measuring our changes in certain staffing groups. We can look, and we do look on a monthly basis at where we're at in any particular service and how many they've gained, how many they've lost, what's the overall change there. So we are constantly looking. So if we did, for an example, a recruitment campaign in a particular area, we do have the ability to test that and see, did we see an increase as a result of that, and working with our provider that supports us with the technology around that to see how many of those applications came as a result of that campaign. In terms of where we're trying to get to, I'm really sorry if I am misunderstanding it, but where we're trying to get to is an increase in our overall whole-time equivalent staff. In terms of our turnover rates, we are focused on getting that at our target or below target of 15%. But what we're throwing all our efforts in is the whole-time equivalent increase, which is linked to both our recruitment activity and our retention activity.
Okay, that is helpful. I think at some point, Jay, and I'll direct this at Jane if I may. I think it's really good to see the change ideas and really good to see that transformation agenda there. I think at some point it would be useful to try and understand what we think each of those is going to contribute to the overall problem, because I think that would help the board to understand where it might need to invest and where it and help us to make some of those difficult decisions. Because I can see that sorry, I've got your department name wrong, Claire, I'm sure, but I can see that what I'm going to call the HR department, sorry, in old money, is working to improve retention. It's working very hard to get more streamlined processes, and that's great in terms of the second horizon. But I think it's just trying to work out where do we get some confidence that we've got the third horizon right. If that sounds, I think that's what we need. Claire, do you want to come back at me?
Yes, sorry, and HR is fine because that's a move on from personnel, so thank you. And I think, I don't know what Jane would say to that, but I think it's really difficult because some things do take a lot longer than other things to evidence themselves. But the fact is, there are so many things we could throw our energies at. And if I took, just the example of Bex talking earlier about how we might look at processes and such like, but all of that, just as one example, takes investment. So I take your point completely about needing to think really carefully about where do we get the most bang for our buck,
Yes,
so to speak.
yes, exactly. Yeah, that's helpful. Sorry, Anna.
No, not at all. No. So, and this maybe just because I recently, just very struck, raised it earlier about the volunteering. The role of using volunteering as a vehicle for career progression into clinical roles, and I just wonder where that fits. I know you haven't, that you've described a huge amount, Claire, and very frustrating to have to kind of summarize it in such a short time. But I also suppose I think about the workforce being about volunteers, peer support, workforce, that it's actually more than just this. And I worry that sometimes we describe it, only in terms of the kind of employed clinical workforce, whereas actually to think about the whole, and then about the ways in which, volunteering, coming in as a volunteer, ending up as a band 7, those sorts of trajectories are really important. And the one really struck me as relevant was Cathy Winfield from South Yorkshire, who described how they got this project was called Project Search, which is all about enabling young people, with neurodiversity, to gain skills, access, and then go on to gain employment, through that volunteering route. So I'm sure it's the last thing you want to hear is anything about what's happening elsewhere, because the problems are so entrenched, across the country. But I just wonder if there are some innovations like that one in South Yorkshire that might have relevance to us. I don't know. Maybe you're already doing that.
Can I just
Yes,
come
please.
back on that, Peter?
Fair.
Just to say, we have a paper on looking at whether the trust wants to engage in project search in September coming to the exec.
Good, excellent. Thank you. Jane.
Thank you, Peter. The answer to your question is yes, Peter. I think I think that we need to have a smorgasbord of approaches, because the situation is so vast, and we might not be able to get a direct correlation between one thing and another, but we can do some indicative work about what, if we've done an incentive in one area, how much that has had an impact, and so that we're sort of, as we're going along, learning what's working for the people of Sussex, because what works for one area might not work for Sussex.
Yes, exactly.
Yes.
Yes.
And I think it's got to be a sort of a continuous improvement journey of learning as we go and measuring it as we go.
Yeah. And I'm really hoping that one of the things about having an integrated care system is that we can get better understanding of how our labour market is developing, and they can do some of that work for us. So we understand the wider labour market context for Sussex as opposed to other areas. Okay, I'm going to try and attempt now to summarize that. So Claire, I mean, really good to see that we have confidence that we're meeting the trajectory that we set for this year. I think we do understand the huge, if you like, lag factors that there are here in terms of what you've called the great retirement, in terms of the fact that we are trying to compete in an incredibly competitive environment, and it is no mean feat to try and get more streamlined processes, but they still have to be the right processes to get people into the organization. Then when we've got people in the organization, how we make sure that we're keeping them in the organization. And I think we also take some confidence in the range of different initiatives that you're testing out in terms of seeing what might work, and really good then to see some of those change ideas. I think there is something that it's good to hear from Mandy, the need to get the clinical engagement, and that actually we recognize that people are under incredible pressure, but actually we do need that engagement with some of these initiatives in order to try and think more to think differently about roles, and to think differently about routes into the organization. And I think that what I was hoping to, behind my question in terms of understanding, was actually so the board can make some decisions in terms of where we might invest and make sure we've got the right resource behind this, because it does sound like a very ambitious plan. Is that all right for today? So thank you very much. Really, really, really good presentation. I'm sorry I've let that overrun a bit, but it is our biggest risk, and I think to simply force that through in a particular timescale perhaps didn't feel appropriate. But we need to try and pick up a little head of speed now if we can. Moving us on to the Quality Committee report, please. So do I get to Anna first and then to Mandy, I think. Is that right, Anna?
Yes, thank you, Peter. Just very briefly from me. First of all, I wanted to just acknowledge Charlotte, because I know she's moving on. I wanted to acknowledge all that she's done, and obviously contributed to Quality Committee and all the work around provider collaboratives. I think I want to just highlight the continuing, careful management of our response to COVID-19. At the time of our meeting, there were no outbreaks on the wards and no reduction in face-to-face contacts. No services stood down once again. I think also to acknowledge the continuing focus on cross-agency suicide prevention work and the ways to embed those initiatives at the place level. Very much a focus of our discussions. We talk quite a lot about the need for assurance on monitoring the quality of care for out of area placements and the processes in place to ensure that all our patients are receiving high quality care, and the challenges around that. We talked about that. Very much welcomed the opening of the Adult Eating Disorders Provider Collaborative in Kent and Sussex at the end of March. We noted also the continuing increase in reporting of incidents in the safety report, and very much welcomed the new patient safety specialist, the new violence prevention and reduction lead, and the new head of accreditation to lead the work, the quality assurance work with the service user workforce. We received quite a number of annual reports, which were very comprehensive. Pleased to see targets met on physical health checks and the ongoing work on quality improvement and the further data integration to allow accurate reporting. We looked finally at the feedback on our own self-assessment, our terms of reference, and we would like to recommend our terms of reference for approval at this board. And I'll stop there.
Okay, well, I'll just quickly ask the board if they will approve those terms of reference. Those are approved. So can we now move in? Mandy, do you want to, I think perhaps if I ask you now to come in, Mandy, and then we'll go to questions from other board members.
Thank you, Chair. Yeah, so I just wanted to add to Anna's really thorough presentation there in relation to the increase of reporting in incidents. So again, quarter on quarter, there's been that gradual increase, which I think is really key to improving the safety culture within the organisation. And in quarter 4, there was a reduction by 9% of serious incidents within this quarter. We're now highlighting the importance of reporting incidents by joining the staff induction training days as well, just so right at the beginning of people's journey of being recruited into our service. It's front and centre, and our patient safety specialist is attending some of those inductions alongside the governance teams. I also wanted to note that at the beginning of quarter 4, we did highlight that we had a significant number of SI reports overdue, serious incident reports overdue. And this was leading to issues for family members where patients under our service had died and had a knock-on effect for them in terms of timeliness in relation to those reports being submitted to inquests. And we've done some significant work to reduce those overdue reports. And at the beginning of quarter 4, we had 50 serious incident reports overdue. And we now have approximately 8 overdue. So there's been a very purposeful quality improvement plan put in place to address this issue with enhanced scrutiny of the overdue reports, but also enabling the CDSs to really see the connection for families between the knock-on impact for them in terms of the grief process. And I think that's a really significant piece of work. We did have one Regulation 28 report in quarter 4 relating to Jack, who's a patient who had gone AWOL from an SPFT unit, and there's been some significant joint work with Sussex Police in relation to some of the processes around AWOL and a review of the AWOL policy alongside a missing persons template which has been revised to support police and SPFT to work closer together, and is building on some of the AWOL reduction projects that we've had previously within the organisation to enhance that. The only other thing I wanted to mention was there's a real focus now on the reporting of injuries and diseases and dangerous occurrences. So our RIDDLE reporting and making sure that the exec, this is included in our quality highlights reports to the execs on a weekly basis. And I know Anna did mention that violence and prevention and reduction lead and our work around operational caval to just really make sure that we're addressing patient safety and staff safety issues in a really timely manner. And there has been a slight increase in falls, trips and slips, and there are some ongoing environmental changes in inpatient environments that we have put in place to monitor falls risking, including the sensor alarms, as well as environmental adaptations that are underway. So I just wanted to do some of those updates in relation to patient safety.
Okay, thank you very much. Any questions either for Anna or for Mandy? Kevin?
Probably less a question and more an additionality, if that's okay. And apologies about the backdrop. Someone is definitely doing work outside. It was just to also draw attention to the advances in patient experience and patient effectiveness, in particular the work that Ravi has been doing on trying to get us towards a PROM or a ROM for the organisation. So I think it was to add to that, and I am becoming rapidly known as the outcomes person, I know, but I thought kind of important to draw that out. That's okay. And apologies about the backdrop. There's a terrible building works outside.
Okay, right. Any other questions for Anna or Mandy? Joe.
Just to thank everyone for all the papers prepared for this item. I thought that I could see an awful lot of work had gone into it, and I thought actually for many of the reports and summaries, the quality and the level of the information was really helpful, and certainly gave me a much better sense of where we are in some areas. Yeah. So that's all.
Thanks. That's really helpful feedback, Joe. Thank you, because obviously you've been monitoring it over a long period of time, so that's very helpful to us. Thank you.
All right. If there's no other questions for Anna or Mandy, I think we'll move on. But I'd certainly reiterate the fact that I do think it's really very much easier to understand what the key risks to quality are and the extent to which they are or aren't currently being mitigated, and where they can't currently be mitigated. We don't currently have assurance or control in place what the actions are, which is really, really helpful. Thank you for that. If I could now move us to the integrated performance report, please. So I think to John, perhaps.
Thank you, Chair. Peter, I will do what I usually do, but I will do both elements in the absence of Charlotte.
Okay.
So I will provide a brief overview, but then I wanted to bring the board's attention to three particular areas, but be particularly focused on the actions that we are doing and taking in each of those areas. So from an oversight perspective, from a sort of governance and oversight, we have updated the board previously on the recovery action plans that we have in place for each of the key performance indicators, which is off track. We have also described the waiting times recovery action plans that we have in place, and Charlotte and I have completed an initial review of each of those at CDS level a fortnight ago. And as you will see highlighted in the IPR, we are developing a process of deep dives into particular areas of challenged performance. Brighton and Hove adult services is likely to be our first area, and we want that to be both a supportive coaching, but also an assurance mechanism as well. The areas that I'm going to highlight were equally discussed within our ICS assurance meeting that Jane described in her Chief Executive's report. The first is around out-of-area placements. So colleagues will be aware that out-of-area placements continues to be a very considerable challenge for us, as outlined in Jane's report. At the top of the meeting, it is a problem for the total system and is certainly causes impacts across acute trusts as well. In terms of a number of key actions since the last time we met, we developed a joint system-wide length of stay and medically ready for discharge plan with a proposed reduction trajectory of moving to a 10% of our patients being delayed by the end of this financial year. That is between an 8 and 10% reduction over the course of the remaining months until the end of March. We met with our local authority directors of adult social care 2 or 3 weeks ago, and at this point in time, they cannot sign up to that level of change. In July, we completed a MAID week. MAID is a multi-agency discharge event where we engage with all of our system partners and had an extensive focus on all the patients in our acute, dementia and rehab wards whose discharge was delayed. You've heard us talk here before around the work that we've been doing with the PSC, particularly around length of stay. That work has now come to fruition. And I think it's something that I would be keen to talk about more, perhaps in future sessions of the board. But we worked closely with a number of clinical and operational staff running our frontline services to complete quality improvement projects around length of stay. So we asked our staff what they thought would have the greatest impact, and they were worked with and mentored by the PSC, and that was presented back to a number of the executive team the week before last. We've developed a sustainability plan with the PSC, and we will be bringing that to our executive committee next week. The key aspect being is, how do we not lose the benefits of the work that they have done, and how do we scale that up across our organisation? Outlined in the report are some of the challenges that we've had, the quality challenges that we've had in accessing provision within the independent sector, and how we've chosen and tried to mitigate that. And very significantly, we are in the process of developing, in fact, a clinically led plan to stop using out-of-area placements, and how we will be taking that decision in conjunction with our system partners. And that's a discussion that we're having with the Chief Execs Group later this month, particularly in relation to shared risk. Moving on to waiting times. So the board will remember that at the last meeting, I gave an oversight of the waiting times programme, which was around the programme structure, the areas that we were seeking to improve, and the governance approach to that, recognising it was both a performance management and a transformational approach. I don't want to repeat that, but really just to drill down into some specific actions that we are taking to seek to improve the position. So since the last time we met, we've had the external validation has been completed of 5,500 patient records. That has, of course, given us some very rich learning around data quality and other areas that we'll need to take forward. It has also, though, allowed us to make changes to 5.5% of those patient records, patients who've already been seen for an initial assessment, or they actually should have been discharged. So that will have changed our position. Within the adults eating disorder services, we have recruited to backlog clearance workers, and we're starting to see a reduction in the numbers of people who've been waiting for over 52 weeks for an adult eating disorder assessment. And it is in that service that we have started rolling out the clinical harm reviews for the obvious reasons around the comorbidities. Within our CAM services, the board will be aware of the significant improvement within the eating disorder services. However, the CAM services are evidencing an increase in activity. They are doing more than they did a year ago, and that is in the context of increasing referral demand. Our Hampshire CAM services have increased their assessment activity and reduced their long waits over May and June by in excess of 120. We know that we have some data quality issues. We've described those before. Within our IAP service, a number of the long waiters can be attributed to being established to teams that are no longer working, and we have developed and agreed a clinically supported process to how we close those down, and that activity will be taking place this month. The weekly oversight meetings looking at people who have been waiting the longest periods of time continue to take place, and so far they have resulted in us removing 300 patients from the backlog. Particularly mindful of the challenge within our neurodevelopmental waiting times, and that's very relevant in light of the conversation that we had earlier in the presentation that we had from Bex. You've heard me describe before the challenges that we have, the very significant financial implications for making inroads into this area. And at our last local assurance meeting, we secured system support and system awareness of the challenge, recognition that this needed to be done by partners beyond SPFT. However, since the last time, in taking practical steps, we have established the program governance, we now have the program manager resource in place, and we have developed an indicative timeline for the clinical validation work and the procurement of that work that needs to take place before we potentially outsource some of the assessment capacity, and that is between now and in October. Moving on to agency. Agency has already been covered in some detail by Claire, but there are, of course, a considerable number of actions that you've just heard me describe before that we are taking, that are taking place. Whilst we have seen an increase in agency spend, on the positive side, we have seen a decrease in the off-framework agency spend, which is a result of the specific actions that we've put in place, particularly around our acute services, where we have developed a process of control and authorization around an off-agency panel. We are now rolling that out to all of our inpatient services, having trialed it within our adult services. We've centralized the off-framework bookings. We have the roster challenges in place. We are enhancing the bank recruitment. We have developed the recruitment and initiatives board. We are putting in place enhanced agency rates. And I think it's important to stress that the area that requires the greatest attention is around the clinical work to review our approach to enhanced observations on our acute wards, because we know that that drives much of our temporary staffing spend. Peter, I'm going to pause, but I really wanted to try and get across to the board that whilst we've spoken before about the planning and the governance and the oversight of a number of these areas, I wanted to get across some of the actual practical, tangible actions that we are taking. Very happy to take any questions on any of those areas.
Okay. So if we could take, I think perhaps if we separate those as you have, John, if we take out of area first and then we talk about waiting times and then agency. Do people have any questions for John? Osman?
I confess I don't have a question for John,
No.
but I was just gonna, if it was helpful, just add a couple of bits from my perspective on this. So I think it was just, I just wanted to highlight the level of activity that is happening. I think we did start the year very much in it, as you'd expect, planning and developing some of the processes we needed. But I hope it's clear the amount of activity now that is leading to, I think, some improvement within the waiting list position. The validation work has been really important. I suppose it's just for all of us to be conscious of, though, as hard as we work to reduce the waiting list, more people continue to be referred onto the waiting list. And I think there is something about, over the next few weeks, part of the next phase of our work, as John set out, will really be trying to understand with our system partners, how long will it actually take, given continual additions to it, to take it through. But it's not to, it's notwithstanding the incredible amount of work that is happening around the management of the waiting list process. I also just wanted to, is my reflection. I had the privilege of joining the feedback from the workshop sessions from the staff who are involved in the QI work, and it was amazing. It was great to see people so motivated, enthused about being given the opportunity to take a bit of time out to think about small process improvements. And I think it really, hopefully, we've got quite a lot of work coming to our exec over the next week or two around, sets us up for a process for how we can do some of these things. And I think demonstrates a lot of the solutions we don't need to go elsewhere for, actually sit within our own organization. And we just need to find a way to get those staff to feel engaged with it. So I think it was just a really clear demonstration. I know we've talked, and I know Jane's talked a lot about QI approach and how do we embed it. And I think this really is a demonstration of how we're starting to go about doing it. So those were just a couple of points I wanted to make.
That's really helpful. The combination of what John's presented and what you've just said, Usman, is really helpful for me in shaping my thought. I think it would be helpful to understand what is in our gift, what might in the past we'd have expected partners to do that they simply aren't going to do now. So we have to find another solution. So I think that there is a slight tendency, and I'm not saying in this meeting, but I certainly I experience it in the NHS, to be slightly nostalgic for a past that never existed. as if the local authorities were always stepping up and enthusiastic to respond to some of these challenges. But since 2013, they just simply have not had the resource to do. Since the stripping out of 80% of supported people funding, and I think the NHS, in my experience, has stepped back and almost gone into more traditional models rather than stepping into the space. And I think we need to come up with a new compact between ourselves and our local authority colleagues about what they can realistically do and what we might need to actually, and what space we might need to step into. And then I think there are those things where we must have system support. So it's like, what's in our own gift? What do we need to reframe? Because we've got slightly old-fashioned thinking is the best phrase I can come up with. And what actually do we really need to rely on system partners for? And I think that would be helpful in terms of getting that momentum. Would be one comment. Really delighted to hear about the clinical engagement and the work on length of stay. I just wonder what this is saying about our community transformation, because one of the things that we mitigate this by is the development of a consistent approach to crisis houses. It is around discharge to assess. It is around the provision of step down. It is around work getting the flow through the pathway. And I just wonder, are we confident that we've got the community transformation operating right? Because this seems to me to slightly indicate that there's something perhaps not driving as fast as we'd originally anticipated. My final comment, which is very much, I don't think what you've just presented comes through in this paper. I think that the paper reads a little bit a bit processy. And I think if we have got those interventions, we have got those actions, that's great to hear, but I think I have to say that wasn't what I didn't get that feel from reading this, but that's a much secondary issue. The first two are more important. So community transformation, and can we actually think about what's in our gift? What do we need to reframe, and what do we really need to wait for system partners for? Anyone who fancies a go at that, please.
I'm pretty happy to have a go,
okay,
Peter.
Thanks, John, please.
I didn't know if I should use the hand function or not.
No.
So in terms of the first question, particularly around local authorities and what we should step into and what we shouldn't step into.
Yes.
So I think you and I probably have quite similar minds in this, and we've discussed this in the board in the past, particularly around our appetite around the housing pathway and around rehab. So I think that's where we should be stepping, and I think the fact that we're developing the community rehab team in West Sussex through the community transformation, the fact that we are taking forward many of the things within the mental health accommodation strategy certainly signals that. As part of the National Hospital Programme, bidding for National Hospital discharge monies, we put in the discharge to assess business case in East Sussex into that. Whilst that wasn't successful, it signals our intent both nationally and within the local system around how we think we can influence and step into that space. That's very much for adults. For older adults, where we know we have a similar challenge, and that simply the system cannot provide the same cannot provide the care home market at the pace and scale that it needs to do. We have been in discussions, well, I've been in discussions with the new director of adult social care in West Sussex about how we may develop a different, innovative clinical model between us, continuing healthcare, adult social care, Sussex Community Trust, and primary care. How does that link to community transformation? So of course, the rehab element is part of community transformation. And I think the example that I gave around older adults could be very much led at a PCN level and could be very much focused on much more on a primary care basis rather than people having to access those services through a more remote and a more obscure secondary care provision. So I do think there is an alignment. That's very much hospital discharge focused. In terms of waiting times, in terms of where do we need the system, so particularly around the neurodevelopmental waiting times, we will need the system to recognise the scale of resource that is required, the scale of investment that is required to actually for us to make a tangible difference. Where we will need system partners will be around the transformational element of those pathways. So the very transactional, can we do clinical validation? Can we outsource that work? We can just crack on and do that once we have the support around the resource. We will need the system partners to help us within the transformation space, but I don't think there is any reason that we can lead that. That we can't lead that, should I say.
Okay, thanks, John. Usman.
Thank you. And I think John's covered off the key points there. I was going to say, I think we have been clear where we think we're going to need system support. And I think it is, as John said, around the new ND pathways. I think we've been clear around the support that will require in terms of investment. There's a couple of things I just would highlight. We are not alone. And I take your point about how we prepare this paper potentially. And I think we'll take that back in terms of how we can incorporate some of the things that we've described into the document rather than it sort of reading as processing as it does. Yeah. But I thought if it was just helpful to give some context, for example, around length of stay, while we continue to do the work to improve our position for acute adults over 60 days, our length of stay is about 7.8. The national average, or national target is 8, and actually peer comparators are just over. And there's a range of sort of metrics that we've got that we will start producing. I think we've talked previously about how do we sort of bring the benchmarking forward so people have a better sense. I'm sorry we didn't be able to bring it for this paper, but we will for the next one. It's been a little bit of a work in progress, but I take some confidence from the sort of work that the team have done around that benchmark information. That means that we are not an outlier on some of these areas that we've been talking about, and those where we are, they are nationally challenged areas, and in particular that is around the ND pathways. And while we have long waits, there are by and large long waits across all mental health providers across the country, and that's why I think that particular area is going to require the system conversation, because there is a very significant funding request if we're going to need to be able to manage that collectively together. And just my last point, and I think it's a fair challenge around community transformation. Hope colleagues will appreciate that we have been having lots of conversations through the executive committee, most pertinently yesterday, where we had that exact point around which of the community transformation programs do we have to prioritize, because as we've just been through on the workforce position, we don't have all of the workforce required to do all of the things. Yeah. So by the time we have the next board meeting, I think one of the papers, whether it will be through finance or performance, will be clear about which areas we have prioritized and where we have focused the staff, we've focused the recruitment versus those areas where we absolutely want to do, but we're in the context of the environment and our inability to recruit everybody we would want, which are the areas we'd focus on. So that will be something we'll aim to bring back for the next meeting.
Okay, thank you. Any other comments, either on at this stage, either on out of area or on waiting times? Jo.
Thank you. I just wanted to pick up or continue the point in relation to community transformation. I think as a NED, this is the area where I feel we are most at risk, partly because, or mainly because, we receive so little data on what it is that we are doing and what we have available and what the challenges are. Dom, I think you'll remember back in February 2020 when we had that workshop in Brighton on the back of the CQC review in looking at community services. And there was a lot of discussion about what we needed to do. Now, I have no sense of what, if anything, has happened consequently. I know we've had COVID, but interestingly, at the last Mental Health Act and Mental Capacity Acts Committee, one of the points that I made to the committee was that we focus a lot on the inpatient experience, but we have a total imbalance when it comes to the challenge around our community services and community transformation. And I am concerned and increasingly concerned because from a world-led perspective, I cannot say with any confidence this is where we are as a board, this is the information that's available to us, these are the challenges and these are the things that we have prioritized, accepted that we can't do it all. But I would really feel more assured if we had clarity around the 3 key things, or whatever it is decided we will focus on and be in a position to evaluate and monitor and track over the coming year.
Okay.
And I'm sorry, if I could just add, I'm not intending to be mean in making those statements, but I am really concerned. And if the evidence is out there, then it's not getting through. If it's not getting through to me and I'm always poking around, then it says something about the way that it's presented or not presented. Thank you.
Thank you very much. I think that's a point well made. Jane.
Thank you. So Joe, I think that's a fair point, and I think rather than go into a huge amount of detail later, I wonder if I could suggest that we bring back something either to board or quality committee, wherever you feel is appropriate, or even audit or wherever, whichever committee is appropriate, that we bring something in more detail as a deep dive into community transformation and the priorities that we're doing.
Yeah, I mean, I think it's a conversation that we'll think about outside of this meeting, how we frame this. But we have a board strategy session on the 5th of September, and I think we need to and following up on the board away day that we had, and I think looking at some of the really big ticket items that are affecting us, we probably need to look at some of these issues on the 5th of September. I would be concerned about waiting till October when we'll be halfway through the year. So I think there's something about taking stock, looking at the data, looking at the trajectories, and just really thinking about where are we really going to focus in terms of making a difference. I don't want to distort this. I don't want to lose the horizon. I don't want to lose the transformation agenda, but we do need to just think about how we're going to get a grip on the rest of this year. And I feel more, and my point about the paper, I'm sorry, it might probably come out slightly wrong, was that actually I'm more confident from hearing what I'm hearing than I was from reading what was written. That's what I meant. I didn't mean to kick the paper around. Okay, I think if it's okay, and I'm conscious of time, that we move on, but I do think these are clearly, you know, big, both this and the workforce issue is something we need to bring back, and I suggest that we think about whether we can do that in a month's time. So if we move to the Finance and Investment Committee report, I'll come to Nitin first and then to Usman, please.
Thanks, Chair. I will take the report as read. As I mentioned before, we had quite a bit of a discussion on workforce. It's one of the main reasons why we are lagging in our plan. So we have a bit of a deficit already for 2.8 million. A lot of people on this call will remember when we put together the budget for this year, we had some mitigating actions to close off the deficit that we had in the plan. A lot of those actions revolved around workforce. And given the fact that we're already behind this year, we got to remember that we might not be able to mitigate or get those actions that we talked about from last year. So we're looking at a much bigger gap than the 2.8 or 3 million, you know. And it's something for us to keep in mind. Usman and I have agreed we will have another session of the F&I committee, a smaller session, whoever is needed, in end of August to review at cost reduction plans, mitigating actions, and happy for anyone from the non-execs to join that session if you feel that's useful. Yeah. But aside from that, yeah, nothing else for me to highlight.
Well, I think Nitin, I think that's a good offer, but what we need to do is think about what goes to quality, what goes to finance investment on its route to the 5th of September. So we just need to think about what goes where, so that you're helping to shape stuff that they then can make better use of the time on the 5th of September. But that's a good offer. Thank you. Usman, please.
So I'm conscious of the time. I will take the report as read, but I think hopefully people will see from the report that actually it is just a translation of all the issues that we have been talking about. The primary drivers of our financial position, which just for the record are, as Nitin said, a £2.8 million deficit, actual deficit at month 3, which is £3 million adverse to plan. £1 million of that deficit, so a third of that position at month 3, is made up of out-of-year replacements, which we've sort of discussed, and some of the actions we are taking on it. And 1.4 million of that is directly as a result of the excess agency cost. So I'm always careful when I talk about agency costs. Clearly we have vacancies, and so therefore we have to manage those vacancies within the budgets we have, but this is the excess cost in effect that we have to use. Those are the two primary drivers of our financial position. And I think hopefully we've been talking through today around some of the actions that we're taking. I think it's probably worth, from my perspective, just highlighting a couple of additional points. On out-of-area placements, there is a significant program of work around how do we improve our length of stay, how do we try to assess the need for always the admissions, the appropriateness, how do we manage risk, and I think it's fair to say that that is a very multidisciplinary approach. This is not a finance issue. I mean, out-of-area placements cross much more than just the finances. The experience for patients, being out of the county in particular, is not ideal. We don't have the same level of control over the quality of it. I know Mandy and Claire can talk about that much more eloquently than I can. But one of the byproducts of this position is it is impacting our finances. And I think it's really important to note the split in the paper. You will see that over the course of June, we've gone from having about 15 patients outside of Sussex to almost over 30. And that brings with it both the sort of issues that I've talked about, but it does also bring a financial cost because those beds are more expensive. It's also significant transport costs involved with it and other ancillary costs. So it is a focus of action for us, and the additional finance committee that Nitin's alluded to will be an opportunity, hopefully, for us to just be able to go through some of those plans in a bit more detail, to test them with colleagues. But Peter, I take what you've just said, and we'll make sure we work through what the best appropriate way to do that is. On agency spend, I would just be a bit more specific and say it's not new. We've just spent the best part of an hour talking about it in various elements of this meeting. I think we are having to consider, though, in parallel with the long-term actions around recruitment and retention and talent management, there are short-term actions we will have to take. And I think part of those short-term actions are around just trying to change culture and hopefully get people who are currently using non-framework agencies back into framework. And I think that will mean us taking some decisions around potentially which non-framework agencies we work with and how, and if we should. That is all currently being looked at, and John's already alluded to some of the work around making sure that we have got consistency in our approach and use of the sort of observation process, and that there isn't the sort of level of variation potentially that we would not want to see. It wouldn't be a finance director if I talked about the fact £3 million off plan at month 1 on a straight line basis. Clearly everyone can do the math and lends itself to the number at the end of the year. So we're doing detailed work around the forecast, and what that means, we're not going to be waiting until month 6 when we would traditionally do that. That's happening now. We've started discussing amongst the executive team, and we'll present that to a wider audience over the next couple of weeks. It is likely that will result in us having to take some of those standard approaches around recovery that you would expect us to. So we will be reviewing all of the discretionary budget areas. We will be reviewing all of the divisional positions line by line, and it is likely we will end up setting expenditure limits for divisions as we move into the second half of the year in order to address some of the financial positions. It's nothing you wouldn't expect me to be saying, I hope. I will stop there in terms of the financial management side of it. We have got the cash flow position within there. I think it's worth just saying the cash flow at present currently looks relatively healthy. That is also being refined as part of our overall forecast work. but it is clearly worth noting that if we have a continued deficit during the course of the year, our cash balance will reduce as a result, because we will in effect have to draw upon that to cover off the adverse position. On estates and capital, I'm really pleased to say the progress is going really well. We are largely on track where we Q1 with the plan, and as Jane had already mentioned, we were successful in receiving planning permission around the Rises programme, and I and a number of colleagues also presented to the Joint Investment Committee, which is made up of the DH colleagues, I think, and NHS national colleagues, and we wait to get the formal letter, but I think felt like we had a positive meeting and are confident that we'll progress through to the next stage.
Okay.
Before we go to the final FBC.
Okay.
I'll stop there, Peter.
Thank you. So my apologies that we've overrun a bit. What I'm going to try and do is I'm going to try and finish by past, if that's okay. So if everyone could be aware of that when they're asking questions, and if people could bear with me, but we will try and get a hard stop at past. So I've got Kevin, Nitin and Mandy with their hands up. So Kevin, please first.
Ask me to ask a more succinct question, Peter. Okay.
That's exactly what I was asking you to do, Kevin.
I'll try. Yeah, so bearing in mind that we've got a number of things going on with finance, including potentially, as I said, a £23 million deficit next year that's going to come in. It's quite an existential and big question, isn't it? My question is the way in which you spend our money at present, and particularly the settlement between community and hospital services, how much that is prescribed, and how much freedom and flexibility do we have strategically to do something with that? Because I was looking for benchmarking. I found some really good benchmarking data last night, and I'm wondering, so the strategic question around community versus hospital, bearing in mind the comparative expense of each, and do we have strategic flexibility over the next couple of years in looking at those beds versus caseloads, is my question. Long question, sorry.
If it's all right, Peter, I'll just quickly come back on that one, only because I suspect my esteemed chair of the Finance Committee, Nitin, will also have something on this. Kevin, I think the honest answer to that is that's something that we are currently working through in a bit more detail. So Nitin at the Finance Committee has asked for something very similar around where is our level of discretionary spend. I think at the high level, what I would say is almost all of the additional growth funding that has been played through to the trust in terms of the mental health investment standard, the SDF funding, is all quite prescriptive and geared towards being spent on community as opposed to within the acute service sector.
Okay.
So the intention has always been for more of the money to be spent in those areas. What you will all know from our financial reporting from last month, in practice, what has happened is more money has been spent on the inpatient beds. So the additional investment on out of area placement beds plus the acute inpatient staffing, in effect, a significant amount of the funding that was earmarked for potentially community transformation has ended up actually supporting core services within the acute. So we will be doing some work via the Finance Committee around trying to break down where we spend our money, where is discretionary, where we don't have discretion, and we'll then, we'll take that through.
And so implicit in the question was relatively. Is this normal, compared to other areas and that those particularly those beds per population, if you like, those is what we're doing usual, normal, and is it okay for the population, or are we off beam and should we be moving things?
I couldn't speak for everybody. I think it's fair to say that amongst our comparator trusts, we are relatively consistent in terms of the way that split has worked. I think the majority of mental health trusts have really struggled to be able to develop the community transformation in the speed at scale they would have wanted to, because they're still managing the acute bed position. And I think it's fair to say that even amongst the broader health service, acute physical trusts are also struggling to get the community out of hospital services working while they manage, in effect, what happens within the acute setting. So I don't believe we're an outlier on that.
Sorry for the follow-up question, Peter.
But one of the things that we have been good at in mental health is actually redefining what a bed is and where it needs to be. And that a bed doesn't have to be an award to be a bed. Haven't we? Sorry, that was meant to be a... Nitin and Mandy.
Just two quick comments. Number one, as Usman said, we are pulling together. So I mean, Usman is kickstarting a project to look at our discretionary spend. I think it'll be great to bring it back to the board and have a bit of a discussion. I'm sure it'll raise some more questions on what we can do. Number two, I think John already mentioned this, but I just wanted to highlight our non-framework agency spend has gone down from March to now from 56 to 42%. And that's been, had it not been for that, we would have been looking at a much bigger deficit. So there's been good work done in this area. We just need to make sure that we keep doing that work and expand to other areas and see what we can do in other parts to bring our spend down. But yeah, that's it from my side.
Thank you, Nitin. That's really helpful. Mandy.
Thanks, Chair. I'll keep it brief, but I suppose just from a quality and safety perspective, it's really key that we are really close to both the out of area and the temporary staffing initiatives and work streams. It's really key. We know that the treatment closer to home from a patient experience perspective and a patient safety perspective is where we want to get to. So having senior leadership within those core work stream has been really important and really supported, I think, by John and Charlotte's really the quality improvement aspects that Usman mentioned in terms of really inspiring some of those clinical leaders to come up with some of those solutions around length of stay, and also within the e-rostering and safe care, we've had the first steering group in relation to safe care project, and the level of engagement within that has been really good to see. So I think from a quality and safety perspective, it's really key that we are close to that.
Absolutely, absolutely. It's a quality finance challenge, not just a finance challenge. And I think we all understand that. Mandy, thank you very much. Thank you, Usman. I think that we note the risks and the issues that we need to address. I think we welcome the fact that you're going to have an additional finance and investment committee, and then look forward to that then feeding through to a broader board discussion in September. I'll leave it there for today. Jackie, thank you for waiting. I'm sorry to keep you waiting. If it's okay with the board, since Jackie, the Freedom Speak Up Guardian, is here, can I suggest we take her now and then we come back round to the Audit Committee and the Board Assurance Framework? Is that all right with everyone? And I'm particularly looking at Joe, and Joe's nodding, so that's great. Thank you. Jackie, so we want your report, but brevity is our friend. And you're on mute, or you might be on mute. I can't hear Jackie. Can anyone else? No.
Into my computer. Can you hear me now?
Yes.
Ah, that's better. Apologies, there might be some background noise. Very briefly put then, I joined this meeting about 6 months ago when I was new in post. And since then, obviously, my role has been full-time as the executives had an expanded Freedom to Speak Up role. They wanted a full-time person who was more proactive. So we're starting to see the benefits of that executive decision. Obviously, I'm out and about physically and out and about remotely, but also there's been an awful lot of comms work and also a lot of support from the executive to encourage more people to speak up. So we have slightly more people speaking up than last quarter, but we have 3 times as many speaking up compared with last year. And this starts to move us towards what's happening nationally, where more and more people are speaking up. So I just want to acknowledge, I think that's an achievement.
Well done.
It's a sign that things are going well rather than a sign that there's a problem. So I just want to say that. The other main thing that I suppose I want to report today is that there is now new national guidance for boards around speaking up policies, and also board toolkits, which is the plan that the board commits to improve in speaking up. So we've already started the process of adopting the new national policy, which I think is very accessible. And there's also plans to meet to start reviewing the toolkit for the board. So all of these things are up to date, but we've now got new guidance which we're implementing. And lastly, just to say that it's not in the report, but obviously between now and the next time I report, we will have National Speak Up Month in October, and we already have plans underway to do more promotional work then. So I'll just leave it open for any questions, Chair.
Are there any themes coming through? You say there's an increase in the numbers of people speaking up, which is great. It's what we want.
Good.
Are there any particular themes?
Well, I mentioned them in the report, and
Yes.
you know, I suppose, I know it seems rather obvious, but I suppose we talk about rising levels of patient demand and complexity, and I suppose we're seeing that in the people speaking up, talking about the impact on staff of having longer waiting lists, of worrying they're not giving the patients the service they need, or the impact on them that patients might be upset and angry speaking to them because they've waited a long time, and the pressure that frontline staff feel with that, really. So I don't think any of it's very surprising, and there isn't any surprises, but in a way people are talking about the issues that matter the most.
Okay, that's helpful. Thanks, Jackie. Any questions for Jackie? Anna?
Just a very quick comment, and thank you for your report. I mean, I think that the fact that you've got 62%, you know, lack of support from managers, it feels to me like that's quite an important trend to be socializing and talking about, and that's not to lay the blame at the door of managers, but to say, look, we've got a disconnect here with what managers are trying to do in terms of support and what actually people are experiencing, or something around that is framing it in a way that says, we know we've got a trend here, we want to tackle it together. But I do think, I mean, it's back to your points about, you know, actually, how do you get, you know, it's all very well for Messenger to say, you know, organizational improvement, but how do you get organizational improvement without more staff and more resources? And I think that's the challenge back to that high level report, really, from my perspective. But really great to have this report, and great to have you, Jackie.
Absolutely. Thank you. Jane, was there anything you wanted to respond to?
So I think that management question is really pertinent, Anna, and it's something we've been thinking about, and the collective leadership and the just culture piece of work, and really how we're progressing that. And I think the other bit is triangulating. We've given Jackie the opportunity, that an open invitation to exec, that she can come in any week and put a slide in and come to talk to any freedom to speak up things that are concerning her that she feels doesn't have traction on. So I think there's something about how we look at the trends, but we also respond immediately when there's a concern. And I think it's the balance of the two.
Brilliant. Thank you. Mandy, did you have your hand up?
Yeah, I was going to add the part about triangulating the information, and also that a panel has been introduced as well, that myself, Jackie and Claire Webster and John take part in, to review all of the freedom to speak up escalations that need to be reviewed. We also met with the National Guardian, didn't we, Jackie, a couple of weeks ago, who was really impressed with the level of engagement around freedom to speak up over the last quarter, and was saying that really, we talked about triangulating the data alongside the patient safety data, the effectiveness data, and the patient experience data, and they were asking us to present some of the work that Jackie's put in place over the last quarter as good practice and a significant change in the organisation. So well done, Jackie, for your work.
Thank you.
Thank you for all your support from the exec as well.
Brilliant. Thank you. Joe.
It's okay, I'll let it go.
Right. So Jackie, I mean, I think so it's really good to see that there's an increase. It's really good to hear the themes, good to hear that you've got access to decision-making parts of the organization. And I mean, I think what we always want to do is we want to give you a slot at board. And although sometimes obviously that's quite a short slot, but clearly any time you think there's a serious issue, you only need to come to me and we can make a slot available to you, or we can create a bigger slot. But hopefully you would always feel that you had access to the executive team, and the executive team was picking those things up. But clearly you do have direct access to the board any moment you want it.
Thank you, Peter.
Thank you. I'm sorry to be a bit brisk, but it's really good report. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye. So can I now move to the Audit Committee? And my apologies.
Thank you, Chair. I'll take the report as read. Any questions? No. In that case, can I ask the board to approve the Audits Committee's terms of reference for 2022-23?
Yes, they're approved. Thank you very much indeed.
Yeah, over and done.
Lovely. So in terms of the board assurance framework today, we do need to just stand back and check that the risks are accurately captured there. I think there is still a little bit more work to do on the board assurance framework following on from the board away day, but I think until we get the output from the board away day, until we sit down and discuss the output from the board away day, we can't do much more on the board assurance framework. I suppose my question is that, do we feel that the board assurance framework is actually driving the board agenda? Do we feel there's anything on the board assurance framework that we're not bringing to board? Certainly Dom and I do use it as a way of making sure that it is driving our discussions. But if anyone feels that there's something there that we're not really looking at, then that's very helpful for me. Dom.
Thanks, Peter. So very quickly, the paper also signals, arising from a conversation we had as the executive team, the updates and revisions that we need to make the board assurance framework this year. We're going to further describe them in detail coming out of an exec conversation in 2 weeks' time, and we'll then be in a position to discuss them more fully with the board in the changing system context and in the context of some of the challenges we have as a trust in the board.
That's really helpful. So are people content with the board assurance framework and content that we're using it? Yes. Okay. But as I say, we will there's a feeding through that we need to complete, and then we'll stand back, and as Dom rightly points out, we'll then think about how we reframe it. Is there any other business? No? Okay, thank you very much. Can we stop the recording, please?